Welcome to Roadmap to Residency. Hello everyone, I am Aviraz. Welcome to our Club 250 Matchmaker sessions. We will be running through a few questions with you guys to help you on a journey to 250. So here we have, which of the following factors is most strongly associated with the pathogenesis of osteoarthritis in this patient? So a 60-year-old man, Mr. Thompson, presents to his primary care physician with the chief complaint of persistent joint pain and stiffness, particularly affecting his knees. He describes the pain as most pronounced after prolonged periods of inactivity, such as getting up from a chair or after walking in the morning, and notes relief with movement. On physical examination, crepitus is appreciated during the joint motion, and there is evidence of bony enlargement of the affected knee joints. Radiographic imaging of the knees reveals joint space narrowing and the presence of osteophytes. Now, given the clinical presentation and imaging findings, the physician suspect osteoarthritis. To further understand the potential risk factors contributing to the development of OA in Mr. Thompson, which of the following factors is most strongly associated with the pathogenesis of osteoarthritis in this patient? Rheumatoid factor positivity, HLA-B27 positivity, obesity, ANA positivity, or history of recent infection. So option A, or rheumatoid factor positivity, is associated with rheumatoid arthritis, which is an autoimmune inflammatory arthritis and is not a characteristic feature of osteoarthritis. SLB27 is a genetic marker associated with spondyloarthropathies, such as ankylosing spondylitis, not osteoarthritis. Obesity is a well-established risk factor for the development of and progression of osteoarthritis, particularly in the weight-bearing joints, such as the knee joints. The ENA positivity is associated with autoimmune diseases such as systemic lupus erythematosus and is not a characteristic finding in osteoarthritis. The infections, especially those affecting the joints, can contribute to the inflammatory arthritis, but osteoarthritis is primarily a non-inflammatory condition. So the most strongly associated risk factor for the development of osteoarthritis in our patient seems to be obesity. The obesity contributes to the mechanical stress on the weight-bearing joints, leading to the degeneration of cartilage and the development of osteoarthritis. Weight management is an important aspect of both preventing and managing osteoarthritis in individuals at risk. Now let's discuss some of the high-level points about osteoarthritis. So definition, so osteoarthritis is a progressive degeneration of articular cartilage that mainly targets the weight-bearing joints or joints that are used very frequently, exam joints in the hands and feet. Epidemiology, it is a non-inflammatory joint disease and it has no sex predilection, almost universally present in those older than 65 years of age. And the risk factors may be advanced age, Alzheimer's disease, um, endocrine or metabolic conditions like acromegaly, chondrocalcinosis, hemochromatosis, osteochondritis dissecans, and sometimes by obesity or trauma, like obesity in our patient, neuropathic joint, and meniscus injuries. The common sites include the femoral head, knee, cervical and lumbar vertebra, and hands. If it involves the hands, then it means that osteoarthritis is usually of genetic nature. The least common sites are shoulder and elbow, and feet with the exception of the first metatarsophalangeal joint. So MTP joint is the site of for bunion formation. So here you can see the pathological changes in the osteoarthritis. The fragmentation and loss of cartilage denude the subchondral bone, which undergoes sclerosis and cystic change. So here you can see the sclerotic bone, and there are some bony cysts that are there, and these are the cartilage fragments, and these cartilage fragments produces the crepitus. So in osteoarthritis, here you can see that there is the irregular joint space, fragmented cartilage, the loss of cartilage. You can see the reactive bone, that is the sclerotic bone here, and the cystic change, that is the subchondral cyst inside the bones. And when the osteoarthritis gets advanced, then we can see the osteophytes, okay? Here, these are the osteophytes and periarticular fibrosis and some of the calcified cartilage. Now, talking about some of the clinical features of osteoarthritis, so pain is the most common complaint. The osteophytes irritate the synovial lining. Bone drops on the bone, and hip osteoarthritis may refer pain to the groin. The pain is aggravated with movement of the joint, and the pain is caused by secondary synovitis from osteophytes. The joint stiffness occurs after inactivity, waking up in the morning and after sitting, and the crepitus of the joint with movement and decreased range of motion may be uh, uh, experienced in these sort of patients. The hand involvement osteoarthritis, generally there is the enlargement of interphalangeal joints, which is caused by the osteophytes, and the osteophytes are called as the Heberden nodes, which is the enlargement of the proximal PIP joints caused by the osteophytes. And these osteophytes here are called as the Bouchard nodes. Now, whatever findings in osteoarthritis include degenerative disc disease and compressive neuropathies causing pain, paresthesias, and atrophy of muscle. The osteoarthritis, you can see the knee X-ray of the osteoarthritis. This is generally seen in your examinations. So knee radiograph demonstrating the osteophytes, okay, and the medial joint space narrowing with osteoarthritis. The most significant finding to identify the X-ray of the osteoarthritis is through your clinical vignette and looking at the X-ray of the knee joint. So generally they provide you with the X-ray of the knee joint, and the thing that you have to appreciate here is the joint space narrowing in the case of osteoarthritis. You can see how close the two bones are here in the joint space. Now, you can also see again in this picture the joint space narrowing. Now, this is the typical feature or the typical picture of osteoarthritis that is present there. Now, also you can see this is the Heberden nodes of osteoarthritis, and these are the Bouchard nodes of the osteoarthritis. Okay, just only the locations are different. Now, again, we have one more question. So, which of the following medication is most likely responsible for the adverse effects seen in this patient? A 45-year-old woman comes to the office for follow-up of arthritis. For the last year, she has had fatigue, weight loss, and progressive joint pain in the hands associated with prolonged morning stiffness. Past medical history includes hypothyroidism, for which she takes levothyroxine. The patient does not use tobacco or alcohol. Examination shows Duffy swelling involving the multiple metacarpophalangeal joints in the both hands. Following initial diagnostic testing, a multi-drug treatment regimen is started. Now, soon after the treatment begins, she develops painful mouth ulcers and nausea. LFT shows a new aspartate transaminase and alanine transaminase elevations. Which of the following medication is most likely responsible for the adverse effects seen in this patient? Hydroxychloroquine, methotrexate, minocycline, naproxen, or prednisolone. So the patient is a middle-aged woman with polyarthritis, morning stiffness, and systemic symptoms, which has typical features of rheumatoid arthritis. Methotrexate is the preferred first-line disease-modifying treatment for most patients with moderate to severe rheumatoid arthritis. Methotrexate is a folate antimetabolite that halts the purine and pyrimidine synthesis through competitive inhibition of dry hydrofolate reductase. Methotrexate preferentially inhibits the growth of rapidly dividing cells such as inflammatory and neoplastic cells. That's why it slows the disease progression in case of rheumatoid arthritis. However, this inhibitory effect can also cause toxicity to tissues with rapid cellular turnover, such as oral and GI mucosa, hair follicles, and bone marrow, causing ulcerations, alopecia, and pancytopenia. Methotrexate can also cause hepatotoxicity, causing hepatitis, fibrosis, cirrhosis, and a pulmonary fibrosis in some cases. Now, let's talk some of the theory about the rheumatoid arthritis. So, systemic disorder associated with chronic joint inflammation that most commonly affects the peripheral joints. Epidemiology, female to male ratio is 3:1. In women, it typically occurs at the age group of 30 to 50 years and is the most common joint disease in women. Various human leukocyte antigen associations that involve the intracellular signaling and production of some types of synovial citrullinated proteins are present in rheumatoid arthritis. There are some microbial agents like Epstein-Barr virus, parvovirus B19, and mycoplasma species, which may be associated with RA flare. Now, the risk factors include age, female sex, tobacco use, obesity, and silicosis. The Kaplan syndrome with rheumatoid arthritis and intrapulmonary nodules is caused by the inhalation of coal dust, silica, or asbestosis. So whenever there is a spectrum of occupational lung diseases, there may be lung symptoms plus the joint symptoms that may be there, and it can hint towards the rheumatoid arthritis. The pathogenesis of joint disease may involve both type 3 and type 4 reactions. One proposed mechanism is CD4 plus T helper T cells are activated, leading to the release of pro-inflammatory agents. Now, the inflamed synovial cells then express an antigen that triggers the B cells to produce the rheumatoid factor. That's why the RF factor is increased and may be a marker of rheumatoid arthritis. The RF is an IgM antibody that has specificity for the Fc portion of IgG. The RF and IgG join to form the immune complexes, and that is the type 3 hypersensitivity reaction. The RF sensitivity is 60% and specificity is 80%. So the RF can also form complexes with IgA or IgG. The immunocomplex activates the complement system to produce C5a, which is a chemotactic agent for neutrophils and other leukocytes to enter the joint space. The chronic synovitis and pannus formation then eventually occur, and then the pannus is a granulation tissue that is formed within the synovial tissue. The pannus proliferates and releases the cytokines that eventually destroys the articular cartilage. Now, eventually, there is destruction of the joint, the cartilage, and the rheumatoid arthritis has finally progressed to its peak state. It can lead to the fusion of the joint by scar tissue called as ankylosis, and then the bone erosions are caused by the osteoclast. And you can see the schematic presentation of pathological changes in RA. So you can see this is the normal joint, and you can see this is the rheumatoid arthritis, where there is the formation of pannus, there is inflamed synovium, there is loss of cartilage, and there are some of the bone erosions that can be seen. And again, you can see there is the osteoporosis occurring along with ankylosis in case of advanced stages of rheumatoid arthritis. So these are some of the hand features called the swan neck deformity, which is the hyperextension of the proximal interphalangeal joints and hyperflexion of the distal interphalangeal joints. The Bouchard deformity with marked flexion of the PIP joint and extension of the DIP joint is shown in the picture number B here. Now, it is there you can see the radiograph of the hand in rheumatoid arthritis. The radiograph shows the periarticular osteopenia and bone erosion that is there, which is compatible with the inflammatory arthritis in the patient with rheumatoid arthritis. Now, talking about some of the clinical features of rheumatoid arthritis, there is the symmetrical involvement of the MCP and the PIP joints, and it notably spares the DIP joints, the distal interphalangeal joints. It causes the bilateral ulnar deviation at MSP joints and morning stiffness for more than 1 hour. And there is the radial deviation at the wrist. We can see swan neck deformity, the Bouchard deformity, and the radiographs of the hands show bony erosions around the involved joints and periarticular osteopenia. There can be some lung disease like chronic pleuritis with effusions and interstitial fibrosis. Some hematological disease may occur like the anemia of chronic disease, Felty syndrome, and autoimmune hemolytic anemia may also be seen.